First, to talk about the challenge of what I see as stigma and discrimination, and to say in practice what are the implications of these issues. Secondly, to say something about the emerging evidence that we can reduce stigma and discrimination. And third, to offer you some practical materials and resources in case you might find these interesting or useful. First, what do I mean by the challenge of stigma and discrimination? So much of what I will say is drawn from a book I wrote a few years ago, which I thought would be a book about stigma. But in fact, after I had prepared writing it, I changed my mind, and instead I wrote about discrimination. So I'll tell you why. It seemed to me, and I like to try to simplify things, that stigma can be seen as a problem of three particular issues. First, the issue of the problem of knowledge, namely that most people in most countries know very little about mental illnesses, and much of what people do know is actually wrong. So this is the problem of ignorance. The second is the problem of attitudes, emotions, feelings, affect, which are almost entirely negative, both from people in the general population towards people with experience of mental health problems, and sometimes also people with mental illness towards themselves. The third is the problem of behavior. Do people actually get a job or keep a job if they disclose having experienced mental illness? Can you find or keep a marital or close intimate partner if you're open about such experiences? And this is the behavior domain of discrimination. And I'm going to argue that this is actually the most important of the three. Now, interestingly, we have in my country a group that produces guidelines, treatment guidelines in the healthcare domain for practitioners. And one of the guidelines isn't about treating asthma or hypertension, but it's actually about public health, population-level changes. And they came to exactly the same conclusion, that one could actually differentiate knowledge and attitudes and behavior. Sometimes in educational research, this is called knowledge, attitudes, and practice, or knowledge, attitudes, and skills, but they're the same ideas.
At 16, in 1996, I suffered a bad mental breakdown where I was hospitalized for 5 years. It was very traumatic. There I was, the eldest son, suffering a sudden deep depression, crying and unable to work, often threatened by my confused dad as being weak.
So this is an example of a problem in the first domain, that of knowledge. So the father here is using a moral theory or explanation of weakness or laziness rather than a health-related explanation for the son, for example, who may be staying in bed or not going to college. So are these trivial problems that I'm talking about? No. So here's an example, which is a national public opinion poll conducted by one of our polling companies. And the question was, in your opinion, in society, who is discriminated against most? Now, I was very worried to see down here people with ginger hair. But on the other hand, since I don't have much ginger hair left, I was reassured on this point. But right at the top here, above all these other groups, people with mental health problems are seen to be the group in my country most discriminated against. So these are not trivial problems. So does it matter? Does it have any practical implications? And I say that it is important, and I'll give you a couple of examples. The first, that it's associated with dying earlier, maybe much earlier. You can see here, for example, data from a recent study in 3 Scandinavian countries, Denmark, Finland, and Sweden. This shows life expectancy after the age of 15 for people who do not have a mental health history in light blue, and the dark blue people who do. And there are a couple of important points. Women are dying 15 years younger on average, men 20 years younger, and although general life expectancy is going up over the 20-year period, the gap is not. So the inequality or the disparity, even in these rich and relatively egalitarian societies, is not closing. So this was published in the British Journal of Psychiatry, and I was asked to do a commentary as an editorial. And I call this a scandal because I think it is. And then about a year later, another study was published from Western Australia, also based upon record linkage between different case registers, and found almost exactly the same results. And then strangely, the BMJ asked me to do an editorial on this. So I was now getting really fed up to see all these data reinforcing the same disparities. So I said, this is a form of lethal discrimination. And the editor of the BMJ said, careful, careful, these are strong words. Can you make it a bit softer? And I said, no. I think this gap in life expectancy is shocking. So it's often said in international policy discussions that funders and national and international ministers and officials will prioritize HIV, TB, and malaria in immunizations and vaccinations, and now some non-communicable diseases, but not mental health, because our sector is not a killer disease, as it's described. So my point to you is in policy discussions to say, yes, it is. And we are talking about significant mortality as well as morbidity, often being associated with mental conditions. The next issue I want to mention about an implication, a consequence of stigma, is how far governments ignore the problem altogether. Now, on one hand, we know about how common these conditions are, affecting us, a quarter of us each year, a half of us in our lifetimes with diagnosable conditions. Yet we know that the best any country can do is to actually offer treatment to about a third of people with mental health problems. That's America. The worst we do is in countries like Nigeria, where World Mental Health Survey data show that as few as 2% of people with mental illness may receive treatment. Now, is that because these are poor countries unable to offer any health care? Well, let's have a look. These are, again, data. These are from a colleague of yours in Holland, Hans Ormel. Again, using World Mental Health Survey data, looking at percentages of treatment among 3 indicator physical and mental health disorders. So if we look here, these are in the poor countries. We see a half, at least, in some cases more, of people with these physical disorders are receiving treatment. If we then look at the opposite, which is in the high income, the rich countries here, we'll see that something like a third of people are having treatment, and in the poor countries, perhaps about 10%. So it's not a question of the absolute amount of healthcare resources available. It's a question of their distribution and lack of distribution towards people with mental health problems. So my second key message is it's actually unacceptable to have these forms of disparity persisting over decades now across countries in the world. Now, I'd like to say something about seeing stigma and discrimination from the point of view of people with the mental health problems. And I want to refer to a study, an amazing collaboration called Indigo, including Jaap van Wegel and colleagues here in Holland and colleagues in many other countries. So this is an association of people now across 39 countries of the world, you can see here, to undertake research about stigma and about discrimination. And first of all, we wanted to actually look directly at this behavioral, you remember the knowledge, attitude, behavior, at the third behavior domain, and to measure discrimination as experienced, as reported by people with mental health problems. And at the beginning, we had a problem because there was no scale, no measure to do that. So we then created this, which is called Discrimination and Stigma Scale, or DISC, and then we used that in a number of studies. The scale, where does it come from? It comes from focus groups, initially in about 25 countries around the world, of people with schizophrenia who were asked, have you experienced discrimination, and in what areas of your life or your experience? And we came out with these very much the same as the important areas for anybody else with or without a mental health condition. And then we went on to use the scale to describe the nature and the severity of discrimination. And first of all, the experienced discrimination. You can see here that friendships, relationships in the family, neighbors, and the workplace came out as highly rated, this by over 700 people across many countries in the world, people with a diagnosis of schizophrenia. But as we developed the scale, we learnt that it wasn't as simple as people without mental illness sort of sending discriminatory arrows or missiles towards people with mental illness. There were also ways in which people with mental illness were engaged in these processes. And we then described this as anticipatory or anticipated discrimination. This is an idea quite similar to the ideas of internalized or self-stigma. So, for example, when we developed the scale and we were piloting it, I sat down with a man at the Maudsley Hospital and said, "Since you have become unwell, have you applied for a job?" He said, "Nope." But he said it far too quickly. So I said to him, "Well, please tell me more." He said, "I'll never work again." So I said, "Well, that's interesting. Please say more about this." He said, "Everybody knows schizophrenics can never work again." So he had not applied for a job since he became unwell. He had not been discriminated against by an employer. And in fact, he had discriminated against himself first because he expected to fail. So it's a why try type situation. So we call this anticipated discrimination, and we then developed a subscale of the DISC measure to assess this. And to our surprise, we find this was actually very common. We found, for example, that 2/3, again over 700 people around the world, had stopped themselves applying for a job because they expected to fail, and about the same, about a half, had stopped trying to form a personal or intimate relationship because they thought it wouldn't be worthwhile. So we wrote up this paper, first of all, about the results in schizophrenia and published it now 4 or 5 years ago in The Lancet. And people said, "Well, that's all very well." People tend to say negative things, don't they? They said, "Oh, that's all very well. But schizophrenia is the worst condition," they said. "And people with depression, it would be much less." They wisely said, "Yes, it would be much less." So we said, well, that is an empirical question, and maybe we will test that. So in a second study, again with now an enlarged set of countries, up to 39 countries involved, we looked at the same issue for people with a clinical diagnosis of major depressive disorder. So the essence of this is that the results were remarkably similar. For people with schizophrenia, 90% said that they had been discriminated against. For people with major depression, 80% said they'd been discriminated against. And the profile of the experienced and the anticipated discrimination were remarkably similar. And that's being reinforced by some of our results in England, showing that it's having had contact with the mental health system itself that seems to be the main driver of discrimination, not the particular diagnosis that you have. So, if you accept that stigma is pretty common and can be something that causes serious implications, for example, for social exclusion, and I just should stress, not everybody suffers, if you like, or bears schizophrenia. Some people have remarkable resilience or ability not to be negatively affected, but it is common. So if you accept that, can we do anything to reduce stigma and, we hope before long, stop it entirely? So the answer again is yes, and I will tell you why I say that. So first I'm going to talk about local interventions that might take place, for example, in a setting very much like this, or that you've heard from the service user group might be in smaller groups, let's say coffee table discussions, or in small groups. So we've had a number of studies on this based upon a simple idea. And if, after an hour or even a day following this talk, you remember anything from this talk, I'm going to say this more than once, if you remember anything, please remember 2 words. That's social contact, social contact, social contact. So that's my main message today. I can leave now. So what does this mean? Well, it's the ideas, in fact, a Dutch researcher described this now in 1928, but very well elaborated by the, one of the founders of social psychology, Gordon Allport, talking about intergroup theory. And the idea is that personal direct contact between a stigmatizing and a stigmatized against group is one of the most powerful ways to reduce stigmatization. So, in fact, recently in a systematic review, Pat Corrigan, Chicago, has also shown that the social contact has the best evidence for reducing stigma among adults. There are fewer studies of stigma reduction among young people and children, and it looks like the evidence there also supports social contact, but particularly supports educational formats for delivery of such interventions. So we've actually done several reviews recently, I'll say a bit more about this, of the stigma intervention literature, which support this once more. So let's look at some examples. So we've done studies of trained police officers, studies of young children, young people, 14-year-old school students, medical students and others, nursing students. And again we've shown that in the immediate pre-post comparison, and then in up to 3 or 6 months following an intervention, we can show improvements in knowledge and attitudes and behavior if the content of the intervention actually has knowledge and attitude and behavioral components. It has been thought historically that if you do awareness raising, which are knowledge activities, then there is some automatic sort of cascade, so then attitudes will improve and then behavior will improve. Increasingly, the research evidence does not support that. What you put in is what you get out. If you have a knowledge intervention, you may get a knowledge outcome improvement. Similarly for attitudes and behavior. But you cannot expect cross-category improvements to happen by themselves. So we've now done a series of studies looking at this within small group settings like today, perhaps a bit smaller, maybe 20, 30, 40 people. Now, that's all very well, and we know that in many situations this works. But it's time-consuming, and it's quite expensive, and it's also emotional work to support people to be trained to do direct face-to-face contact and to support people to be debriefed and transported and reimbursed and so on. So we then looked at the question, is it true that filmed social contact experiences are as effective as live experiences or not? So this is a study with nursing students, and we had 3 conditions. We had two live service users talking about 3 things. First, about what it's like having the condition. What is it like to hear voices or to feel suicidal thoughts, for example? Secondly, what is it like to have contact with the mental health system, to be in hospital or taken to hospital? Third, what is it like to experience the reactions of other people, maybe your family or your friends or your neighbors or your employer, when you're known to be a mental type person? The second condition were filmed clips very, very similar to the content of the live contributions. And the third was a boring nurse lecturer talking about categories of mental illness, a boring lecture very much like mine today. So then we looked at knowledge, attitudes, behavior. We also went a little bit further at this study, and we looked at compassion. We hypothesized the live patients would have strongest effect, then the filmed, and then the lecturer. And we were wrong. So the live and the filmed versions were both as effective as each other, and both were better than the standard lecture. But we also added in a health economic assessment, and we found that the filmed version was much more cost effective and suitable for wider use on a large scale. For example, through social media, we could actually reach thousands, not just tens of people. So increasingly now we're seeing some actually very useful summaries of the literature. This is from a group in Canberra, led by Kathleen Griffiths, about effectiveness of programs for reducing stigma and looking at the randomized controlled trial evidence. And they said interventions targeting personal stigma, social distance have found effects. Usually these are small or modest effects, not huge. This isn't eliminating or extinguishing stigma. These are making incremental improvements. Again, they found the importance of consumer contact and educational interventions were important. And interestingly, they've said that internet interventions are at least as effective as face-to-face contact. So this opens up very important aspects for future practice and research to trial filmed interventions because they have so much more potential for large-scale change. Now, there's one exception to the social contact rule, or possible exception, which are healthcare staff. So commonly, in surveys of consumers and service users saying who, in your experience, discriminates against you, people will say primary care staff, mental health care staff, emergency department staff. And yet, these staff have so much experience, knowing experience of contact with people with mental illness. So why are they perfectly unstigmatizing if they've had so much social contact? So we've just published, a couple of weeks ago, a review led by my colleague Claire Henderson on this question. And this paper is simply to describe that there's now strong evidence that healthcare staff are a big part of the problem. So we can begin by acknowledging that. What should we do about it? And they've looked at the evidence for interventions for healthcare staff to reduce stigma. And these are the summaries. Social contact can be effective, but it needs to be more. And in fact, it should be a mixed approach of several elements. A personal recovery testimony element, multiple forms of social contact, teaching skills to staff about what to say and do. You might imagine staff would already have those skills, but perhaps not. Myth-busting and enthusiastic facilitators. And if you combine in multiple forms, then you have a better chance of reducing stigma among healthcare staff. But social contact alone simply won't do. So that's a bit about local level interventions. Next, I'm going to say something about interventions at the large scale or at the national level. Now, you can see here that there are beginnings or more developed campaigns, including some in your country, at the larger scale level. The earliest ones were in New Zealand and in Scotland. But in recent years, you can see many others have come along, including in my own country, in England. What sorts of issues are these campaigns trying to tackle? So we can see here an example about a museum in Japan saying those with mental disease are declined to enter the museum. And this is an interesting one for health staff here. In some countries in Asia, if you're a person with a mental condition, you cannot go onto an aeroplane unless accompanied by a psychiatrist. So if you'd like to travel in Southeast Asia, you know where to look for a job. So what are the key active ingredients of population-level interventions? So from a recent program of research called Sapphire, which I led along with my colleague Sarah Clement, we did a review of that question. Again, we found the idea of recovery orientation came out from the literature. Personal stories, again and again, individuals telling the experience, telling stories, are very popular, especially on websites and social media sources. Focusing on social inclusion and using continua or continuum-based, not category-based views of mental health problems. So not that it's them, a few people have got it, but everybody can be affected, it's common, there are degrees of issues and so on. So it's that everybody can have these conditions at some time in our lives. So I want to say a little bit about a campaign in England that started in 2008. It's called Time to Change, and this is the biggest, and I think the best campaign that we've ever had in my country. I know about it because our team at King's College London is the so-called evaluation partner. Initially, the government wasn't interested really in this, and it's funded by a lottery, or lotto, I think. Do you have a lottery in Netherlands? Okay. And then it's called Comic Relief. This is a thing on television where famous people fall in mud or fall in the water, and then you have to phone in and give money, and they make millions of pounds, that type of thing. So in fact, they had never given money to mental health before. They were nervous. They didn't know if it would be popular. It was very popular. So it's a whole series of interventions, some of which are radio, film, TV, local events. This is in the Tube or the Underground, the Metro in London, with a poster on the wall. Lots of multimedia ways of conveying the message, but the message being consistent but carried across different levels and different streams of media. So, to cut a long story very short, the first 4 years we used, it's called Phase 1, and we evaluated this in many different ways. You'd be very welcome to contact me to get the details of this, and we published the main results here as a series of 8 papers in the British Journal of Psychiatry. But if I can summarize 4 years' work in one slide, we found a consistent pattern of positive changes in many ways of assessing the impact of this campaign. For example, we had annual national opinion polls. For example, every year we phoned up 1,000 people across England in contact with mental health services. For example, we had polls of hundreds of senior managers in industry and in organisations. We found that these were small to moderate sized, and we used the framework, again, of knowledge and attitudes and behaviour. We thought that knowledge changes would be simpler and easier and we'd have bigger changes, and again, we were wrong. The biggest improvements came in the domain of experienced discrimination, and after 4 years, reported by people with mental health problems across England, there was an 11% reduction in experienced discrimination. So I want to give you an example of this as an idea of these campaigns going viral. And in one of the early films, we deliberately we drew upon a previous mental health film, and this was then picked up by colleagues in the United States and subjected to a cultural adaptation.
Hi there. Sorry to disappoint you if you're expecting a lunatic on a rampage. I'm Kalen, and I've been living with schizophrenia for 11 years. People like me with a diagnosis of mental illness face stigma and discrimination every day. Luckily, I've had the support of family and friends to help me live a full life.
It's time to talk about mental illness. Start the conversation and pledge to end stigma at bringchangetomind.org.
So this is an NGO, a charity set up by Glenn Close, really because she wanted to work with her sister and her nephew who have bipolar and schizoaffective disorders to do everything they can to reduce stigma. I mentioned earlier the idea of social contact, and if we want to use this to its full extent, we can actually experiment and be creative. I've heard this morning about coffee table experiences, which I think are very similar to this idea. And this is something called a living library. This is a shopping centre in eastern England, a place called Norwich. It's a sort of open and safe environment. And here you don't borrow a book for a week, you borrow a person for maybe half an hour. So she has got the T-shirt, so this identifies her as the person with experience of a mental health problem. He doesn't have the T-shirt. He's got a somewhat shocked expression on his face. So he can't believe what he's hearing. And when we debrief people, both with and without experience, interestingly, both generally find this a very positive way of mediating, of priming social contact. So here is a man called Kvel Bondevik, and he was the Prime Minister of Norway. And he had an episode of depression in 1998. He was then the Prime Minister of Norway, and he, interestingly, one morning he just couldn't get up. He was in bed, and he couldn't manage to get out of bed. He contacted the Deputy Prime Minister, and he said to him, "I can't get up." And the Deputy Minister said, "Goodness me." And the Prime Minister said, "Well, I think I have depression, so I can't be Prime Minister at the moment. So you'll have to take over running the country." And the Deputy said to him, "Well, okay then. What shall I tell the population?" And the Prime Minister said, "We shall tell it like it is." So the Deputy told the country that the Prime Minister had depression. Interestingly, within 2 months, he was back and well enough to work again. And then 2 years later, he stood once more and was re-elected as Prime Minister of Norway. And there are a few examples now, actually. There was a Premier of Western Australia also who disclosed openly, and there is a Mayor of Taipei in Taiwan. I'm collecting examples. There are a few, not many, who also has been quite open about his mental health problems. And not many politicians do this. So this woman's not a politician, she's my mother. And here we are on holiday last year in Scotland. So why am I telling you about her? Because when I was small, just after my sister was born, my mother developed a severe depression. She had different antidepressant drugs, which were useless. Then she had electroconvulsive treatment, which very quickly helped her. In fact, after 3 treatments, she recovered. So she was working before this as a district nurse, and she had a year off from work. So I said to her, "When you went back to work, what did you say about why you had been away and sick?" She said, "Are you stupid? Are you mad?" I said, "Nothing. Absolutely nothing. Because if I had said why I was sick, then I wouldn't have had my job back again." But she didn't say anything, and she did go back to work, and then she worked another 20 years as a community nurse before retiring. And this is when it happened, and that's me at the age of 3 or 4. And interestingly, a colleague who does a lot of stigma research called Pat Corrigan wrote to me and said, "Would I like to write a chapter for a new book he's doing about my experiences of mental illness?" So I said, "Well, I'd like to, but in fact, I've never been treated for mental illness, but my mother has." So I said, "Shall I do a chapter with my mother about her experiences and my memories of that time?" She said, "Okay." So we just finished that chapter, which is it's really interesting to work with my mum on that. So I've talked a bit about one exception of some of these interventions, which is healthcare professionals. Another exception is we have not made much progress yet in my country improving attitudes in black and minority ethnic groups, because generally they have not been specifically targeted in these campaigns. And also we haven't, until recently, had a specific focus on young people, but now we're beginning to address this, and I'll give you an example. Okay, Pygmalion by George Bernard Shaw. Can you open your exercise books, please? You've got a 1,500-word essay to do. I'd like you to choose one of the themes from the board and start to plan it. Ah, the Wanderer returns. It's another 2 weeks behind. See me after class.
So where you been this time? Somewhere warm? Yeah, your mum's bed.
Yeah. Okay, settle down. Are we a comedian as well now, Michael? As I was saying, choose one of the themes on the board and start planning your essay.
Yeah, I've got one for you. How many teachers does it take to change a light bulb? No? Alright, how many depressed people does it take to change a light bulb? Doesn't matter, it's always dark, isn't it? When you wake up, you got a dead arm. You can't control it, can't make it do anything. Imagine that in your whole body, in your mind, your whole life. Remember when I was off school? Remember all the jokes? What options you choosing, Michael? Getting out of bed? staying awake, coming to class. Only that's when I was so low. Getting out of bed wasn't an option for me. Even on Facebook. Changing my status to still skiving. It's funny, isn't it? It just makes it a little harder. Sometimes it's already too hard. I mean, you lot are my mates, right? Right?
We've also looked in detail about these issues with a systematic review about health-related stigma and help seeking. This was published just a year ago now, led again by my colleague Sarah Clement, and that explains exactly how far stigma contributes. It plays a part, it's not the biggest part, but it plays an important part to preventing people getting treatment and care that they may need and benefit from. Again and again, I'm talking about social contact, which depends upon disclosure. We all know many people with mental illness, even if we're not directly involved in the mental health sector, but most people don't know that they know people with mental illness because those people are busy actively trying to keep it quiet. So we have a review here about disclosure in the workplace. And I'm also beginning to think about some of the wider implications of stigma, for example, in relation to suicide. So let's try to imagine a world in which there was no mental health stigma. In that world, would we expect suicide rates to be less? Would people go for help earlier? Would more people get help? Would people with severe depression be more likely to be treated before, for example, they get to the point of suicide? So we've done a couple of papers last year about that. This one is from my colleague in Germany, Nicholas Rusch, an overview of some of the issues. I'm especially interested now, not so much in describing reality, but the point, however, is to change reality, but in terms of interventions that do and that will reduce stigma. So we've done a very detailed review, two actually, one a systematic review, one a narrative review on this question. And this paper is now in press with The Lancet as an overview about all of the data we have about discrimination and stigma and interventions. Now, in the next part of the talk, I'm going to move from sort of research, academic lecture, into advocacy mode. And this is in red as a call to action, because I'd like you to act. And I'll tell you what I'd like you to do. You may know that in 2000, the United Nations created Millennium Development Goals for health and for wealth across the world. Health goals, for example, referred to mother and child health, HIV, TB, and malaria. I think to the shame of the United Nations, they said nothing about mental illness. And those goals finish this year. And following that, there will be new goals being called Sustainable Development Goals for the next 15 years. And at the moment, there are 5 words in this many-page document which at the end of one little target says, and mental health and well-being. So I don't think this is good enough. So I'm trying to raise awareness, that's knowledge domain, about the issue, to prime behaviour. Maybe I should follow my own advice and have a behavioural input. And so I wrote this paper with my colleague Vikram Patel about the issue in August in the BMJ, and there are several other papers recently we've written about it, saying we should have a stronger presence in the Sustainable Development Goals on increasing treatment coverage, having more people receiving treatment, on reducing suicide, for example. One of the more recent papers is here led by my colleague in Nigeria called Oyo Gereje, and we now have a consortium of about 40 organizations across the world who have joined together into an alliance to press for stronger mental health content in these Sustainable Development Goals. So let me say a little bit about why we think this is important, briefly. This is an alliance across these different organizations of many groups, many individuals across the world. And we've come together to form a group called Fundamental SDG. You can find us at that website and also at this Twitter site here. And we're particularly keen now, because this is the end game, most of the final discussions will take place in the next 2 or 3 months, to get governments to support our proposals to strengthen these goals. So if you have contact with officials and preferably with ministers in your health ministry or in your overseas development and aid ministries, please do link up here or talk to me as well, perhaps over lunch, about how we could try and press for these important changes. So to summarize, I've wanted to do 3 things in this talk. First, to say something about the nature of the challenges of stigma and discrimination, especially as experienced and reported by people with mental health difficulties directly. Secondly, I wanted to summarize the evidence that we can effectively intervene both locally and nationally, and in my opinion, we should. And third, I've offered you some resources. Now, if you'd like any of these papers or scales or films or other materials, please do contact me. The simplest way is I can then invite you to join a Dropbox folder where we've got all these materials freely available to you. And if you wish, you can follow me on Twitter. So on that note, thank you very much for your attention.